Varsha. Yeah.
Right. Okay. I would like to thank the President, Prof. Sampath Gunawardhan, and the committee members, Executive Committee of the Gold Medical Association for giving me this opportunity to talk to you all on COVID-19. Let me start my presentation. Before that, I have to share my slide. Can you all see my slides on the screen?
Yeah, we can see Varsha. Yeah, we can see Varsha. Go ahead. Thanks.
Right. Okay. COVID-19 pandemic has been going on during past 1.5 years. By now, we have a better understanding about the virus, the disease caused by it, and its implication on our human body. With that, let me start my talk today. What is exactly COVID-19? As you all can remember, in December 2019, a brand new coronavirus was identified for the first time in Wuhan, China. The virus is given a name, a SARS-CoV-2, that is Severe Acute Respiratory Syndrome Coronavirus 2 since then. It's RNA virus and it's called corona because it has a crown-like appearance on its surface when you see it under the electron microscope. It causes a respiratory illness, which is called COVID-19. How does it spread? It's also spread the same way like the other viruses causing the respiratory diseases. It's through the respiratory droplets. When these droplets are produced, when an infected person coughs or sneezes, this can land on your mouth, nose, pharynx, throat, or sometimes directly inhaled into your lungs. So this spread occurs between people who are in close contact with one another, especially within 6 feet radius. Right. So it's important to understand the pathophysiology of this disease and the different phases or stages of the disease for you to plan the investigation and to use various therapeutic modalities modalities in timely manner for a better outcome. Right. So the process starts with the viral entry. Once the virus enters the human body, especially during the early phase, it prefers the epithelial cells in the respiratory tracts. So it mainly targets the cells such as nasal, bronchial epithelial cells, and pneumocytes. So the virus then it binds to these epithelial cell ACE2 receptor by using its surface protein called spike protein. Then it enters into the cells. ACE2 receptors are the functional receptors for SARS-CoV-2 virus, and they are highly expressed on these epithelial cells in the respiratory tract, particularly nasal mucosa and the pulmonary mucosa. That's why it's preferred these sites most. Once the virus enters the cells, it undergoes maturation, replication that result in release of millions of viruses into the system. Right. So by this time, usually about 1 to 2 days following the exposure, due to this increasing viral load, the host immune system recognizes the viral entry, and it activates its innate and humoral immune response. Due to this activation of the innate immune response, that result in production of more and more chemokines or cytokines and releasing those cytokines into the system. We call production of pro-inflammatory cytokines. And due to the effect of these cytokines and direct viral invasion of the cells, the epithelial endothelial barrier integrity is damaged, causing endotheliitis that predispose microthrombi formation, especially initially within the pulmonary vasculature. We call the microangiopathic vasculopathy. At the same time, activation of your humoral immune response that start producing antibodies against the virus. However, the severity of the disease is not determined by the viremia or the virus load. The key determinant of the disease severity is the magnitude of the host immune response. So the disease can vary. Some people can be asymptomatic, though they are positive for the COVID-19, right? Then some of them can have only mild disease, moderate, severe disease, sometimes with organ failure and severe hypoxemia. Let me explain this process further using this diagram. The red line on your left-hand side indicates the exposure of a person to the virus, so viral exposure. And the second red line is the time that you develop symptoms. So the period between the exposure and to the onset of the symptom we call the incubation period. So the incubation period for this COVID-19 can range from 2 to 14 days. But in majority of the patients become symptomatic on the 5th day following the exposure, right? So this line indicates the symptom onset, right? You can appreciate, I hope you can appreciate this purplish line that indicate the virus load in an infected person. By the time you become symptomatic, you have the maximum load of viruses in your circulation or in your system. So during this phase, the patients are very infectious because they have the high viral load. Right. Actually, patients become the infectious couple of days prior to the onset of the disease. So it can vary from 0 to 4 days prior to the symptom onset. They are contagious because their virus load is rapidly increasing during the phase. Right. So during this phase, due to the viremia and the activation of your host immune system, patient can be symptomatic. So what are the common symptoms they can manifest during this phase, what we call viral symptomatic phase, the first week following the onset of the symptom? They can have fever, headaches, myalgia, and sometimes the loss of taste and smell, and occasionally GI symptoms like nausea, vomiting, and diarrhea. 80% of the patient feels better by the end of this week. So, and the rapidly the clearance of the virus load at the end of the first week. So this is due to successful control of viral replication and propagation by limited yet healthy immune response, host immune response. So they will be less infectious after the first week, like by the end of the first week, and they will have this disappearance of these symptoms, and they feel better. 80% of the cases, this is the scenario. But however, about minority of the patient, about 15 to 20% of the cases, this is not the scenario. In fact, they will feel more ill. They will become more ill, then they will have worsening symptoms, existing symptoms, or appearing more new symptoms by the end of the first week or the beginning of the second week. So they are entering from this viral symptomatic phase to inflammatory phase. So they can have a worsening of the existing symptoms like worsening cough, increase in the height of fever, and sometimes they can be very short of breath even on mild exertion. They can be very hypoxic, tachypneic, tachycardic, and hypotensive. And in hand, you can observe these, the evidence of inflammation going on by, by lab investigations, like they can have high CRP, ferritin, LDH, D-dimer can be positive, and troponin can be positive, and so on. But as you all can appreciate, during this phase, the virus load is minimal, it's clearing rapidly from your system. So it's not the viremia is responsible for these symptoms and the worsening disease during the inflammatory phase. Is the worsening of the disease during this phase is due to dysregulated immune response causing hyperinflammation, hyperinflammation with production of more and more cytokines and more endotheliitis, widespread, the thrombi formation, and so on. So the COVID-19 primarily involved the lung. So due to this ongoing pulmonary endotheliitis, there can be diffuse alveolar damage, and these alveoli can be filled with fluids that can cause ARDS. So that is the cause for hypoxia during this phase. And not only that, due to the widespread pulmonary intravascular thrombosis, due to the endotheliitis, that can add to this, the picture, and the loss of hypoxic constriction, vasoconstriction, that causes significant VQ mismatch. These are responsible for significant VQ mismatch, that causing hypoxia during this phase. Right. So there are two types of ARDS described in COVID ARDS. But I'm not going to talk in details about this type of ARDS in COVID, but in briefly. So there are the L type and the H type. L type is the milder form of ARDS with relatively low VQ mismatch. So they are not symptomatic or hypoxic at rest, but on mild exertion they can be hypoxic. We call silent hypoxemia and hypoxia. The H type is the full-blown ARDS with high VQ mismatch and profound hypoxia, and they are overtly symptomatic. Right. So this process, the same mechanism will not limit it to heart, the lung by this time. It can involve the other organs. For example, if it involves the heart, the coronary arteries can be involved with the diffuse endotheliitis, with disruption of the blood flow within the coronary arteries, that can predispose thrombi formation and myocardial infarction, myocarditis, heart failure, and the cardiogenic shock. And the same process can involve the other organs like brain. So the patient can have stroke due to the stroke and the ischemia. Sometimes the activation of the dysregulated activation of the coagulation cascade due to diffuse the intravascular thrombosis. They can have even bleeding. So the patient can have stroke secondary to bleeding as well. And the encephalitis, encephalopathy, they can be delirious. The same process can involve the other organs like kidney, liver, and so on. So you all can understand. So this process, this period, the inflammatory phase and the worsening symptoms and organ involvement and hypoxia is not due to the viremia, it's due to the inflammation. So this is the rationale behind starting immunomodulatory drugs during this phase and starting anticoagulant during this phase to try and control the inflammation, try and control the thrombosis, widespread thrombosis. However, starting the immunomodulatory drugs, especially steroid, before this phase, when the patient becomes hypoxic and ill-looking, and the patient in this inflammatory phase, before that, if you are going to start, immunomodulatory drugs, especially during the viremic phase, is dangerous. But it can cause persistent viral replication and the continuous viral replication and progression of the disease and complications. So that is why it's not indicated to use the steroids, especially the immunomodulated drug steroids, before this stage. Right. So by the end of the second week, the early third week, the bacteremia and the fungemia and other bacterial infection can occur due to increasing incidence for multiple reasons, which can further complicate the picture. So this is, by this time you can understand the patient has going on, with the infection, viral infection going on for more than 2 weeks. So immunocompromised. On top of that, during this inflammatory phase, early inflammatory phase, we may have started the patient on immunomodulatory drugs, further compromising the patient's immunity. And sometimes the patient can be exposed unnecessarily, inappropriately to antibiotic during the initial stages, like especially the first week when they're having only mild symptoms. So that can worsen, that can cause antimicrobial resistance. So everything is responsible for the possible secondary infection during the secondary infection phase. So by this time, the because of the dysregulated host immune response causing hyperinflation is going on. Then superadded infection, fungal infection, bacterial infection can can cause worsening the clinical picture. So they can go on and involve the other organs. So multi-system inflammatory phase they can enter. So this is the basic pathophysiology of COVID-19. And let me So this diagram further explain what is happening in mild COVID disease, the patient with mild COVID. So this is the symptom onset. This arrow indicates the symptom onset, and they have the highest amount of viruses at that time. They are very infectious, but most of them become they feel better, and their symptoms go away by the end of the first week, and their viral load is clearing, and they become non-infectious, and they feel better now, and they recover without any complication. But in severe disease, they will not feel better by the end of the first week. Further, they will have worsening symptoms. So they will enter from this mild disease to moderate disease or severe disease, worsening hypoxia and ARDS, and the superadded infection can occur during the end of the second week or the third week. So that multi-organ involvement, sepsis, can develop and can cause the clinical picture. So this is happening in hand with increasing inflammatory markers, which you can detect from the blood, with, as I explained earlier, high CRP, LDH, D-dimer, ferritin, and so on. Right. So symptoms of mild COVID-19, I think I can skip this slide because I have already explained. So then we'll move to the manifestation of severe disease. So the respiratory system is the mostly primary involved the system with COVID-19. They can have viral pneumonia to start with that can progress to ARDS, and because of the inflammation that progress to organizing pneumonia, that the picture can be complicated further by bacterial or fungal infection. So if it's the heart, so they can have myocardial infarction because of the thrombus formation, endotheliitis, hypoxia, and sometimes they can have stress cardiomyopathy. So heart failure, arrhythmias, and shock. So it's a thrombogenic situation because of the endotheliitis, hypoxia, ongoing inflammation, and so on. So that could predispose not only the venous but also the arterial thrombosis. So pulmonary embolism, TVT, active stroke, myocardial infarction, and limb ischemia. So they can have multiple neurological complications, stroke, encephalopathy, and so on. So these are coupled, these happen hand in hand with increasing, inflammatory markers that can be detected in your blood. So with increasing CRP and so on. So the picture can be, aggravated by secondary infection. It can involve the other organs like acute kidney injury and the kidneys and the liver. So risk factors for the severe illnesses is recognized. The increasing age, male sex, and comorbidities are the risk factors associated with severe illness in COVID-19. So the few words about the categorization of the disease severity. There are 5 main categories of disease according to the severity. They are the asymptomatic patients. So they are positive for the SARS-CoV-2, but they are completely asymptomatic. Mild disease is defined as the COVID symptoms, but no evidence of pneumonia clinically or imaging, and they are not short of breath. They are just mildly symptomatic with headache and so on. So these patients are being managed at level 1. And moderate disease is defined as the COVID pneumonia, but less hypoxic and less tachypneic. And severe disease, the COVID pneumonia with profound hypoxia and tachypnea and more lung involvement. So they are being managed at level 2. And the patients have the respiratory failure, other organ involvement, shock, and so on. They are called critically ill patients. So these patients, as well as some of the refractory cases of severe disease, are being escalated to level 3. So I think with that, I come to the end of my presentation.